bonito es el día que acaba de empezar, bonita la vida. Respira, respira, respira. El teléfono suena, mi pana se queja, la cosa va mal, la vida le pesa, que vivir así ya no le interesa, que seguir así no vale la pena, se perdió el amor, se acabó la fiesta, ya no anda el motor que empuja la tierra, la vida es un chiste con triste final, el futuro no existe, pero yo le digo...
Hi everyone, welcome to today's webinar. We're going to give folks another minute to join, but in the meantime, we'll listen to some music and hope you're having a great Thursday so far.
Todo me parece bonito. Bonita la paz, bonita la vida, bonito volver a nacer cada día, bonita la verdad cuando no suena mentira, bonita la amistad, bonita la risa, bonita la gente cuando hay calidad, bonita la gente que no se arrepiente, que gana y que pierde, que habla y no miente, bonita la gente, por eso yo digo bonito, todo me parece bonito, bonito, todo me parece bonito. Qué bonito que te va cuando te va bonito. Qué bonito que te va.
All right, so thank you for joining us for today's webinar. We wanted to kick it off with a little bit of music. For those that are not Spanish speakers, the song is called Bonito, which means beautiful, and the lyrics are really just inspirational and just to remind us that, you know, there's beauty in every day. And I know with the challenging times that we've had this year, you know, hopefully each of you can find a little bit of joy and a little bit of beauty in each day. So again, thank you for joining us for today's webinar. We do have a wonderful session for today. Today, we're going to be talking about aligning social needs data and social interventions coding for health equity. Right. So just wanted to go over a little bit of housekeeping. Today's webinar will be recorded, and we'll be sure to send any resources and next steps afterwards through email. And we also have been posting our slides and the recordings on our website as well. Just a couple tips on Zoom. I know we've all been well acquainted with Zoom in this virtual world. Just wanted to remind folks to use your Q&A platform within Zoom. That's a great way for us to track all the questions that you have and make sure that we answer them. But then also use the chat feature. That's a great way to interact with each other and to chime in with any questions or thoughts or reactions to the content that's being presented. And again, we are under new realities. So we've got kids at home, furry friends, unstable internet, renovations, all sorts of things. So if something happens, please let us know. But we'll be sure to you know, manage any sort of, hopefully any challenges on the front end. So here's today's agenda. My name is Rigadela Cruz, and I'm going through the opening and the housekeeping. We'll be having some. The next topic will be an overview from Rosie Chang Weir and Vivian Lee from AppShow, and then we'll hear from 2 community health centers about their experience and what they've been doing so far today. And then obviously we'll have some time at the end for Q&A and just going over some resources and any closing comments. So the learning objectives for today's webinar is to identify and review existing social interventions data, collection and protocols, and provide technical expert insight for national standardization, provide on-the-ground perspective and recommendations for integrating social interventions, including the social service referral loop in alignment with the social service sector. And then finally, foster discussion around best practices and lessons learned in existing processes, use cases, scenarios, workflows, and reporting to document SDOH interventions. So this is our team here at NAC and at AppShow. We have a long-standing collaboration. So this is the team. Wanted to highlight our newest addition to the team member, Nalani Tarrant. She joined us a couple months ago, but we wanted to just highlight and just reintroduce her again since she's new to many of us in the field. Today's guest speakers, we have 2 wonderful guest speakers for today. We have Marty Sabol from Nasson Healthcare, York County Community Action Corporation, as well as Corinne Hanson. She's from the La Maestra Community Health Centers. So just wanted to introduce them. Hold on one second. Pull up. So Marty Sabol, he is currently the Director of Health Services and has been with the organization for quite a while now. He's been intricately involved in healthcare systems in Maine for nearly 35 years, with strong experience in the areas of prevention, healthcare coverage, infectious disease, and case management. Prior to beginning his tenure as Director of Health Services at York County Community Action Corporation, Mr. Sabol worked for the City of Portland Public Health Division, first as the manager of infectious disease program and later as disease intervention specialist. He has also worked as the Director of Healthcare Coverage with the Maine Primary Care Association. And today he actually serves on the board of the Maine Primary Care Association and the Community Care Partnership of Maine. So in his current role, he oversees all health center operations, including staff supervision, grant management, and policy development. Next, we have Corinne. She has served as the Director of Development and now the Chief Development Officer at La Maestra Community Health Center since December 2013. Since her start date, Corinne and her team have been able to secure more than $50 million in federal, state, and private foundation funding for the organization. And this has helped the organization with capital improvement projects and increased services such as substance abuse and mental health services and additional social services, including legal advocacy. She has shared with us that as a person with type 1 diabetes, she's passionate about improving access to primary care, specialty care, and needed social services for all individuals. Corinne has been one of the leads on implementing social determinants of health programs at La Maestra and tracking and monitoring this program as the initial funding was from grants. And Corinne loves working at an FQHC. So that's just a little bit about our presenters, our guest speakers today. Wanted to acknowledge that today's webinar is provided with funding from the Robert Wood Johnson Foundation. We're really excited to be working with them and that they're supporting our efforts here at NAC and APSHO. And just to provide a little bit of an overview, we have, this is the updated theory of change. It's something that the Robert Wood Johnson Foundation, along with grantees, have. This was revised a couple months ago, and wanted to point out just a couple of things in the changes. Some of you may have seen this before, but the main part of the framework is pretty much still the same in terms of shared purpose, data, governance, and finances. However, one thing that's really different about this is the fact that they really come to understand and recognize that community voices, equity, power dynamics, and trust really facilitates or allows all of these different pieces to work. The other thing that we wanted to point out, or that they wanted to point out with this change, is that in terms of this framework, the goal isn't necessarily alignment, it's to work with alignment. And really the outcomes, or what we're looking for in this work, is changes in mindsets, practice, and policy. And this can really be seen towards any sort of progress with community goals and needs, health equity, and racial equity. So that's just a little bit about the framework and kind of the why of what we're doing with this webinar series. So many of you may have joined us back in October. We hosted a series of 3 webinars. And really, we heard from the field, and we wanted to make sure that we were able to provide some tools and resources for our health centers, as well as other individuals within the healthcare landscape and social service sector, and different techniques and strategies for improving how do we address social determinants of health in the time of COVID. So that's a big high-level overview of the why of the webinar series. And here are just some links to those webinars from October, the slides, the webinar recordings. So if you've missed one of them, you can certainly go back and view one of these and just take a look to see what were some of the resources that were shared in them. So now I'm going to hand things over to Rosie and Vivian as they'll lead us into this wonderful presentation.
Great, thank you so much, Yuriko, and I assume you can hear me. Again, my name is Rosie Cheng Weir. Thank you so much for your interest and in joining this webinar today on the topic of social interventions. I'm the Director of Research at APSHO and co-PI of PRAPARE, primarily leading the research and evaluation work of PRAPARE. And APSHO has been a joint partner with NAC since the concept and foundation of PRAPARE, and is probably best known for our work even earlier than that on the development of the data collection protocol for enabling services and social intervention. So I'm leading the project that I'll be talking with you about today on behalf of our PRAPARE team to develop a national standardized process for documenting social determinant interventions aligned with PRAPARE that will be available for testing and implementation by for health centers and their social service partners. Next slide, please. Before we go any further, I just wanted to clarify what we mean by social interventions. So we're defining them as non-clinical services that address non-medical health-related social determinants of health needs. So they can include services such as case management, referrals to community social service partners, financial counseling, transportation, interpretation, et cetera, that you see there on your screen. So why are we developing a standardized social interventions protocol first? As PRAPARE is the leading social risk screening tool used by health centers and Medicaid managed care organizations, and really increasingly used by other health systems, it's really critical that we develop a national standardized system to track the social interventions provided to patients to address their PRAPARE social determinant of health needs. Such systems will enable providers and community social service partners to better communicate and understand the context of how, when, and whether patients' social determinant of health needs that are identified through PRAPARE have actually been met, and by whom, et cetera, so that they can collaborate to provide better and more comprehensive care coordination to close the loop for their patients. So the vision for the development of this National Standardized Social Interventions Protocol is to promote collaborative data collection and aggregation, reporting, exchange, and communication by health centers and their social sector partners and others to comprehensively address social determinants of health and close disparity gaps for patients. So next slide, please. I wanted to share just a screenshot of the protocol we've been drafting. We won't be able to go over everything today, but we've been working closely with the National Technical Expert Panel, of which our guest speakers are part of, and other stakeholders, over the past year to develop this protocol. As seen in the outline, we've developed together the principal social intervention codes that track responses to the PRAPARE social needs, the activity codes or codes for each of the responses, the supplementary documentation that includes things like the length of service provided, and closed loop referral status that we'll be talking to you a little bit about today. We also included and thought about, the use cases, workflow diagrams, and recommendations for reporting and outcomes tracking, so that we could, visualize at the forefront, what the end result of the data could look like. And we're also working on a crosswalk, and we'll continue to work on this based on the working version of the codes that we have. So let's go to the next slide. I wanted to exemplify with a scenario here with and without social needs screening and interventions to kind of give you an idea of the use case of why this is important. So as you can see here, today a care team member is seeing Maria. Maria has been working night shifts and she fell asleep at the stove and almost caused a fire. She has a medical history of uncontrolled diabetes, missed appointments, and poor medication adherence. She was diagnosed with sleep apnea, hypertension, and has dangerously high blood sugar. She was also hospitalized for her blood sugar, given a prescription for hypertension, and placed on a CPAP machine for her sleep apnea. 2 weeks later, unfortunately, Maria is back with the same clinical presentation of symptoms. And the care team discovers that she hasn't been taking her medications or using the CPAP machine because she can't afford them. Let's move to the next slide. And this time, show you a case where her social needs are assessed to better understand how they might interfere with her clinical care. So in this case, in this scenario, the care team member discovers that using PRAPARE that she has social needs that she was positive for, insurance, food, housing, stress, employment, and transportation. In the yellow box, we see that the care team member provided social interventions to assist her with these needs, including assessing her eligibility for insurance, enrolling Maria in the government insurance, providing referrals, making the appropriate appointments, and arranging for transportation to the referred community partners to help provide further resources for those needs. As you can see in the darker pink box on the bottom right, later on, the clinic care team member follows up with the community partner to check on Maria's status. Maria continues to be monitored for treatment plan adherence and seen before the 2-week mark due to her high risk profile. In this use case, if social interventions were not provided based on her assessment of social needs, Maria would continue to have the same issues. In providing the social interventions in a coordinated way and monitoring and tracking the status of her social interventions through improved communication and collaboration with the healthcare and social service providers, we can address the root causes of Maria's needs to prevent the cycle of her social and health conditions, just leading to a much more efficient and effective alignment between systems and lowering costs. Next slide, please. And here are some, I wanted to share with you some more use cases of social interventions, not just from the patient level, but to the policy level. Just some examples on the individual level. The data can help better connect patients and close the loop on social service needs with effective coordinated responses. Health centers can evaluate these services to determine which are most effective for their patients and which interventions are most needed so that they can build the community relationships and use the data to inform advocacy for needed resources alongside community partners and building capacity for communities to address the root causes of health. These social interventions data and the return on investment evaluation on how they improve care and are cost effective can be helpful in payment negotiations to sustain needed services, leading to payment reform to better address complex patient care to close disparity gaps. So let me pass it along to Vivian to share a little bit more about what we've been developing for the social intervention in the next slide.
Thank you, Rosie. So in this slide, here are the social intervention codes that align directly with each PRAPARE SDOH need. So you compare each PRAPARE social need with the intervention and designate whether you responded to the specific social need or not. All these codes would also be mapped and aligned with other national intervention codes, such as the SNOMED code and the CPT codes. For each social intervention, there is a possibility of responding in multiple ways to address the PRAPARE social need. So we also have social intervention activity codes, which are not shown here, to track the specific way of responding to a need. For example, assessment or referral. You can find the full list of the social intervention activity codes in the appendix slides once the slides are sent out after the webinar. Next slide, please. So the following data can be documented to provide context about the PRAPARE social intervention. The data will be useful for reporting and documenting evaluations of your social interventions to better understand the impact and the intensity by intervention. In most cases, organizations may already document this information in their existing EHR or electronic system, and the information can be auto-populated or transferred into the EHR or provider electronic template. By designating these variables here, we can ensure that these variables will be linked in the same system as the social intervention codes for more feasible analysis. Next slide, please. So here, this workflow provides more context about what data should be documented. Those data are denoted in yellow font. So altogether, you would have the data on PRAPARE need, whether the specific need was responded to, what types of services or activities were provided during the intervention responses, and what was the context and setting of the service. The information is then transmitted to partnering organizations such as the social service provider. Then the referrals are tracked and attempts are made to close the social service referral loop until the need is responded to in a comprehensive manner. Social needs will also be reassessed to ensure the need is no longer an issue for the patient. If it still is, you and your partners have contextual data on what you tried, so you can try different strategies that might work better for the patient. So thank you. And now I'll hand it back to Rosie to discuss the impacts of social intervention documentation.
Great, thank you so much, Vivian. So yeah, I wanted to talk to you a little bit more. I think some of you had some of these questions in the chat as well about the importance and impact of the social interventions documentation. Let's go to the next slide. So I think there were some questions about, why collect social interventions when we already have PRAPARE social needs data. So, if you already collect PRAPARE social needs, through this, you'll have a comprehensive understanding of the patient's social needs. But if you don't document the accompanying social interventions that you deliver to address them, how would we know that they have been addressed? So knowing that the social interventions have been addressed is all part of demonstrating value and part of the quality care equation in our value-based pay environment. Our intention from the beginning of our initiative was always to document both sets of data, as we believe they go hand in hand. It's just not enough nowadays just to know patient social risks. The health and social sector needs to provide evidence that they can respond to and manage these risks, often very complex risks, which would result in better patient outcomes and drive upstream change that will be more sustainable and cost effective. Let's go to the next slide. Here, we just wanted to give you some examples of metrics that can be reported through the tracking of PRAPARE social interventions. And so, for example, the number of social determinants screens and the corresponding social interventions. You can do this by month, by category, by provider type. The number of social interventions addressed compared to the number of PRAPARE needs. The number of remaining PRAPARE needs that still require social intervention, so you understand where patients have gaps. You can also track, the mean length of time spent on the social interventions, things like the summary of the patient referral status. A lot of times, health centers may refer patients but do not know the status of whether the patient followed up and what kinds of care were provided by the referral organization. So a documentation of the categories for closed loop referral status is really important for this coordination of care. So, again, you wouldn't have all of this data just by reporting the PRAPARE social needs absent of the social intervention. And we want to, of course, make this as standardized as possible, because there are a lot of folks that may do this, but it's not in a standardized way. Let's move to the next slide. And we just wanted to provide you also, social interventions should be periodically reviewed and evaluated to determine their impact on desired organizational outcomes. And so the following here are examples of outcome metrics that can be evaluated through the tracking of PRAPARE social interventions. For example, is the number of social interventions associated with the reduction in missed appointments, reduction in ER visits and hospitalizations, more timely preventive care, improvement in quality indicators such as A1C. Let's move to the last slide here. I just wanted to end with just some next steps of what we plan to do. Again, we have a lot more developed that we weren't able to share with you today, but looking forward to sharing and getting more stakeholder feedback when that's ready. But for now, our next steps for standardizing the interventions coding aligned with PRAPARE are first, finalizing this draft with our technical expert panel and with stakeholders with their valuable input, and then conducting these Plan, Do, Study, Act evaluations with some organization volunteering to help us test this initially, and then using that information to inform what we should develop within a pilot so that we can do more formally with organizations, and at the same time think about resources for standardizing the national data collection. So again, thank you so much for your interest, and I'm looking forward to hearing any questions you have.
Thanks so much, Rosie. And Vivian, thank you so much for providing this overview and this critical information. We are going to save Q&A for the end, so keep plugging in those Q&As. or the questions in the Q&A platform, and we'll be sure to have them teed up and ready to go at the end of the session. So next, I'd like to introduce Marty Sabol from Nasson Healthcare, York County Community Action Corporation, and I'll hand it over to him now.
Hello, quick sound check. Can you hear me okay?
Yes, thank you.
At the last minute, I was not able to zoom in, so I'm going retro and using a telephone here with the speaker on. So yeah, thank you so much. I'm thrilled to be here. I'd like to tell you about our organization, about our early work with address of screening for social risk factors, social determinants of health, talk through some of our workflows, both here at the health center in terms of screening, diagnosing, and referral, and then some of the social service interventions that happen on the social services side of our organization. So if you want to hop 2 slides, I'm not able to work my slides, I'm sorry. So can you go to the next
okay.
2?
Is the heading outline?
Outline, yes. If you can go there.
Great. I'm there.
Oh, geez, I'm looking at my screen, which is static. Okay, never mind. So yes, outline. So there's the outline. Next slide, please. York County Community Action turns 56 this year. That's not a whole lot younger than me, but we were founded in 1964 during the great expansion of social services and health services during the Johnson administration. During that period, community action programs as well as community health centers, Head Start, Medicaid, Medicare, all were launched. So the mission of our organization, which is similar to many other community action agencies, is basically to address the manifestations of poverty and also attack its underlying causes, and ideally increase the amount of dignity and self-sufficiency among our clients. Go to the next slide. Our service area, Maine, as you can see, is in the upper right corner of the United States, and York County is the southern tip of Maine. We have roughly 200,000 people who live here, pretty evenly dispersed in an area the size of the state of Rhode Island. Largely rural, wooded, some agricultural services here, and then fishing on the coast. Programs that our agency offers include Head Start and WIC, Children's Services. We have a transportation program. We have LIHEAP, low-income heating assistance, weatherization, economic opportunity, and the health center, Nasson Healthcare. Economic opportunity is community outreach, social work, case management. There's some photos. That's our main office in downtown Sanford, Maine. That's sort of a retired textile mill overshadowing our office. Sanford, like many old New England towns, has these rusted hulks of textile mills, shoe mills, and so on that are no longer employing people. There's some shots of our transportation program, nutrition education, children's services, weatherization, and then finally Nasson Healthcare. Our main office is here in Springvale, a section of Sanford. We have a total of 5 sites right now, 7,500 active patients, 18 providers providing medical, behavioral health, dental services. We're kind of a unique community health center to the extent that our roots are as a healthcare for the homeless and public housing primary care. That's the alphabet soup at the bottom there. And with the Affordable Care Act, we became a full-fledged community health center 7 years ago, 2013. We also offer school-based health services. Early on, having a really heavy representation of folks of patients who had really limited means, very low incomes, largely homeless, living in public housing. Every every effort we would make at understanding and addressing our clinical quality metrics was very frustrating. We just always seem to be at the bottom of the list in terms of hemoglobin A1C, prevention, immunization services, and so on, relative to other health centers in Maine. We joined a patient-centered medical home pilot. We got a whole lot of technical assistance. We looked at risk stratification to try to get to the, some root causes for our disappointing quality metrics. We took on clinical integration, working with behavioral health providers to foster work with patients to change behaviors so that health outcomes would possibly improve. We looked at better integration between ourselves, we the health center, and other agency programs, and just continued to sort of flounder with our quality metrics. And around that time, NACHC started doing some work with PRAPARE, with screening for using validated questions to screen for social determinants of health. We were greatly inspired by the work of Bradley and Taylor and their meta-analysis of healthcare systems called the American Healthcare Paradox. They make the point that while in the United States we seem to spend a whole lot on healthcare, our health outcomes are not great compared to other developed places where more investment is made into social services. So here at the health center, here at Nasson, we have a fully embraced screening for social determinants of health. We use the PRAPARE tool. We use the tool to screen initially. Providers have access to screening responses. They are in a position to evaluate and either determine whether this is an acute need, sort of a chronic situation, just totally episodic, likely to pass, and so on. To the extent that it's appropriate, the providers use ICD-10 codes to diagnose states like food insecurity, housing instability, transportation barriers. And to the extent that patients would benefit by just understanding what resources are available in the community, we have printed materials, and we're also now able to refer to case managers, social workers in the economic opportunity branch of our agency. We are able to measure these referrals. Referrals are actually generated electronically through our electronic medical record system. They are received electronically by staff at Economic Opportunity. They are able to intervene and then close the loop by forwarding consult notes to us electronically. We're able to measure the actual screening responses, number of people screened, the screening responses, the diagnoses, the referrals, and then the rate at which those referral loops are closed. When patients receive services in Economic Opportunity, in that office, that program, a social worker basically reviews notes that are part of the referral. They're able to assess using their asset building matrix. They're able to develop plans and then intervene and then forward consult notes back to the provider who has referred. All of our providers are referring, and that includes dental and behavioral health, as well as medical providers, and that is what we have in place right now. We could not do this without a ton of electronic support. We have the next-gen electronic medical record system and practice management system. It is embedded with the PRAPARE template, so information is actually keyed into the system, and during the patient visit with the provider is able to bring up the screen. The ICD-10 codes automatically are included in the assessment unless the provider rules them out if there are positive responses. We're actually able to collect prepared screening responses through a program called I'm blanking here. Anyway, there's a great program that we're able to use. It's called Solution Reach, we're able to text the PRAPARE screening tool to patients in advance of their appointments. They're able to complete it electronically. Unfortunately, it doesn't, that program doesn't interface with NextGen, so we still have to key in the responses, but we get the responses fairly in a timely manner. So again, the PRAPARE template is embedded in our system. It prompts the use of appropriate ICD-10 codes. Those codes then can be used to generate a referral. Within the agency, we have struggled over the years with the question of, how many unique people use our services. We have tended to be fairly siloed. Our funding streams are not coordinated. Our databases are not necessarily coordinated. So we've put a lot of effort over the recent years, into adopting two systems, one called CADS, the other called Empower, which allows us to actually count unique individuals and understand that they are or are not using all of the programs that they are eligible for or would benefit from using. So this is still a work in progress, but it does allow us to track use of our myriad programs. Moving on. So here we are. Right, we've got a whole lot in the works. We're still working out a lot of rough spots. Our goal with the social services interventions, and we're thrilled to be part of this pilot with NAC and NACHC, but we're very interested in better standardizing the social services intervention and codifying them. We're interested in assigning actual cost and value to these interventions to the extent that Maine's actually still not on board with. We're still a fee-for-service Medicaid environment, and we're slowly migrating toward value-based care. And to the extent that we can make a case for our patients' need for social services, and to the extent we can value those social services, we can discuss reimbursement for the whole package. So we community health centers in Maine are having these conversations with our Medicaid agency right now. We're interested too in being nimble enough in our social services to address patients' acute needs that we're identifying. No place to stay tonight, nothing to eat, and no prospects. Versus, this is a chronic thing. The third week of every month, SNAP benefits expire, and our family's hungry for a week each month. We're very, to the extent that we can at least identify and quantify the need and quantify and codify the interventions, we recognize that we just need a whole lot more in terms of resources. And to the extent that our data can make these cases, ours and other Maine health centers using PRAPARE can make the case for better, more robust social services interventions. We're interested in doing that. And then almost finally, we would like to better integrate our screening for social risk factors with other health risk assessments that we do. We're concerned that we're spending a whole lot of time doing these assessments, and there's a fair amount of overlap between, well child visits, caries risk assessments, even in dental, and Medicare wellness visits. So we would love to have a more streamlined approach to risk assessment. And then, what was my last point? It was brilliant, and I'm blanking. Anyway, so I'm going to leave it there. And welcome any questions when we get to questions. Thank you. Are you still there?
Yes, I'm here. Thank you so much, Marty.
Oh.
Appreciate you sharing all of your expertise with us. We do have a couple questions for you, but we'll take them later on. So we'll be, again, just to remind folks, we'll be taking questions later on. Right now, I'd like to introduce our next speaker. It's Corinne Hanson. She's from La Maestra Community Health Center. And thank you for joining us today. And I'm going to go ahead and hand it over to you, Corinne.
Hi, thank you so much. Happy to be here. Yep. So I am Corinne Hanson. I am the Chief Development Officer of La Maestra Community Health Center. If you could go to the next slide, please. Next slide again. And about La Maestra, we are a community health center in primarily City Heights, so central San Diego County. Our mission, like many health centers, is basically to improve access and quality of care for all patients. And our history, we were formed in 1990, and we were actually an amnesty center originally. And out of a group of students, about 12,000 students, they came to our CEO. Our health center was formed in her living room. They let her know that they really needed access to healthcare and that there was not culturally and linguistically competent care for them in the community. And so our CEO is our CEO and founder and fearless leader still. And we're one of the few health centers around still that has a CEO and founder. We have grown significantly. We became a FQHC in 2002 and have grown there. We actually have, if we can go to the next slide, please. We have 5 primary care medical sites in Central, East, and South San Diego County. And we have 10 dental suites. We have a mobile medical unit, a mobile dental unit, and a mobile mammography unit. And right now, due to COVID-19, we actually have several temporary sites. We're an HCH health center and a public health center as well, public housing health center as well. And we have our mobile medical clinic at the temporary shelter, which is being used right now at the San Diego Convention Center for homeless individuals. We have quite a large homeless population that we serve. And so for us, addressing the social determinants of health was really, really important very early on. Let's go to the next slide, please. So this is just La Maestra in a nutshell. We have about 45,716 patients that we served according to our UDS, and we did about 207,788 visits in 2019, and approximately 57% of our patients would prefer to be served in a language other than English. We have a pretty diverse patient population. The large majority is Hispanic. We are right on the border. We are a border region here in Southern California. So we are one of the most culturally diverse and linguistically diverse health centers. Lots of immigrants and refugees in our community. Our staff come from the cultures served. We have a medically trained cultural liaison program that is usually from staff that have immigrated from other countries. They may be doctors, nurses in other countries and have come to the US and they become part of our team. We actually speak 30 different languages and dialects right now. We have about 500 plus employees. Let's go to the next slide. And so we have a fairly innovative model of care. We can go to the next slide. You'll see our circle of care model. It's really about whole person care for us. We have medical services on site, but we also have mental health services, substance abuse services. We have a food pantry. We have transitional housing. We have a microcredit and micro enterprise program. We have lots and lots of job training and placement. We have an after school program. And kind of a unique thing about our health center is that we're not providing just medical, dental, and behavioral health services. We are providing all of these services, many of them on site in our healthcare complex. We have a legal advocacy. We have an immigration attorney on staff. We just brought another immigration attorney on staff. Very excited the news that just came out for DACA. And we're just really, really about empowering the community that we live in and serve. So let's go ahead to the next slide. So we have been working on, we have used very disparate systems for a very long time. As I mentioned, you know, we're celebrating our 30th anniversary at La Maestra, but we have been doing social needs on site for many, many years, for decades really, and we really needed a way to capture it and to really understand our social, basically our social determinants of health a bit better. We did implement the PRAPARE template in 2017. We did a small study we actually, we can go to the next slide I think it's on the next slide, but we really were really interested in doing a PRAPARE assessment, and we have modified, as you can see on this slide, we have modified the PRAPARE template slightly. Our questions, we have about we have 7 questions, and right now during COVID-19, this tool is patients can access it on their smartphone or it can be emailed to them, but it is still part of our intake process, and we're working on setting up basically kind of like a survey tool for them to do this intake assessment using one of our content management systems, which is QuickBase, which we're hoping to integrate into NextGen. We've been working on that for quite a while and we're very, very close. But these are our 7 questions. They have to do with family and home, emergency, have you been in an emergency shelter, or I'm sorry, or permanent housing, transitional housing, short-term housing, and then your money and resources. Have you had access to food, employment, access to healthcare, insurance status, and how have you been able to get transportation, access to your utilities in the most recent time frame. So those are our brief PRAPARE questions that we're using, and we can also do it right now. We're doing it via telephonic and telemedicine visits. Many of our patients are being seen via telemedicine due to COVID-19. So we were able to pivot that, and we're actually using auto in our NextGen system. So we're still able to use our PRAPARE template and to use all of these same features. But then working on developing other reporting tools through QuickBase and our SSRS reporting. So the providers determine right after they do this brief assessment, what social services the patient can be referred to on site. And if they need to be referred off site for something like more permanent housing, or if they need more comprehensive legal advocacy services than we offer on site, then they are referred, and we have excellent referral relationships with our county 211 and other partner agencies. Let's go ahead and go to the next slide. I think it's just a shot of our actual PRAPARE in NextGen. And we were very happy to leverage PRAPARE in our EHR. Just we're working really hard now to just keep everything into one system. We're going from many systems into one system. I keep hearing that a lot from a lot of other health centers as well. So I think that is very, very important. And we'll go ahead and go to the next slide. So social needs screening, as I mentioned, it's all done in our EHR. We're using the NextGen PRAPARE template. We have modified it quite a bit. I don't know if you can see this in the pop-out section, but this is kind of how we differentiate ourselves. We offer all of these things on site. So adult education, Blossoms is our floral arranging service that people, many of our patients get jobs at. We have a community garden on site. We have dental services. We offer eligibility and enrollment assistance in 30 different languages. We have a food pantry. We have our Generations After School Care program. We have health education, transitional housing, comprehensive imaging services. We have a CT scan, full imaging diagnostics for mammography, both in our mobile mammography center and in our comprehensive CT scan suite. We have job training, we have a microcredit program, we have legal advocacy, and optometry, pharmacy. I don't know if you can see the whole list there, but translation and transportation services. Those are all of our on-site services. And then if we find a patient that needs something outside of our on-site services, then the case managers work with our local resource directory, which is in San Diego. 211 San Diego has a very comprehensive resource directory. And we have about, I want to say 165 case managers of our 500 staff. Case management is very much a part of our being and our work ethic, and following up and making sure that our patients are getting case management services is very, very important. And case managers will phone external referral organizations and patients up to 3 times to make sure that they're completing their referral, getting access to those needed services. And then we document all of this both in QuickBase, and then we're working on integrating that into NextGen too, so that it's just in one system. Hopefully, fingers crossed, that'll be very soon. Okay, and we can go to the next slide. So we did a study in 2017. This is a little bit dated, but we did a study of 3,746 patients. We've obviously seen many, many more patients, but this was just our initial study, our initial pilot. The top needs for us were health insurance, eligibility and enrollment assistance, housing, more permanent housing, and then our access to medical care, and transportation, and then access to food. And we do have an on-site food pantry. During this last couple of months, obviously, as many of you know, food insecurity has become a huge issue for us. We've actually quadrupled our food pantry capacity. We've become a super pantry and a diaper bank, which provides diapers and formula to the patients that are in need of that right now due to COVID-19. Our community has been hit extremely hard by COVID. We do have COVID testing, rapid testing, and we're doing drive-through clinics, and we're testing lots and lots of our patients. Right now, we had just last week about 147 patients. Of those, 39 were positive. And so we have a pretty high percentage rate throughout this whole COVID-19 period since March. It's varied between about 19% of our patients to up to 33% of our patients testing positive for COVID-19. We're in a very densely populated area, and these issues are lots of doubling up, lots of homelessness, lots of that going on. So very, very big need here. So let's go ahead and go to the next slide. This is my last slide. So challenges and next steps. We really, as I just went over, you know, these were our top needs: medical care, health insurance, food, housing, transportation. One of our big needs for modifying PRAPARE and continuing to have PRAPARE integrated has been funding, and really hoping that we get it right instead of doing like piecemeal modifications. It would be great to have an all-encompassing system, and that is, you know, we got a really good system out of the box with NextGen, and then the PRAPARE template, but we did kind of tweak it just to make sure that our providers would be on board with doing the assessment, and so that it would really align with the services that we could provide on site as well. So we're really working, the next steps, we're really working on developing and implementing a marketing campaign to ensure that patients know of our on-site services. We actually did a recent study, and we found that many of our patients were not aware of all of the scope of services that we had on site. And then working with 211 San Diego, we are part of their community health information exchange. and really working to do bidirectional referrals with other partner agencies, especially for housing, working with Catholic Charities, San Diego Housing Commission, and others, and really working kind of with the county as well to try to build housing in this very densely populated area. So we're very hopeful of that as well. And let's see, next slide. I think that that's it for me.
Thank you so much, Corinne, Marty, and then also Vivian and Rosie. We're going to now segue into our Q&A portion. So I do see a good number of questions in our Q&A pod and some in our chat box. So I'm going to do my best to answer them and direct them to the panelists today. We are, just a reminder, going over 15 minutes past the hour. So we have about 20 minutes. So please do chat in your questions. That way we can answer as many live. And if we don't get to them, we'll make sure to direct them to our guest speakers today. So I'm just going to answer two of the questions that came in earlier in the webinar during Rosie and Vivian's presentation. A lot of you wanted to ask about the social interventions codes, and are these Z codes or ICD-10 codes? The answer to that is these are more related to the CPT codes and also SNOMED codes, whereas the ICD-Z codes are related to more of the social needs, which again are mapped to some of the PRAPARE questionnaires. So I hope that helps. And then Rosie and Vivian also wanted to allude to that the CPT and SNOMED are not all specific to PRAPARE needs, nor are they comprehensive in the alignment with PRAPARE. So stakeholders from different health centers and different primary care associations have really informed the PRAPARE team on how to better align these systems and to help fill in the gaps when you're collecting some of those PRAPARE questionnaires. And in the slide deck you'll see some of those codes that we outlined. We just didn't want to include those for the presentation today since it's pretty dense. So if you have more questions about the coding structure, please do chime in the Q&A or chat box. The next question I have here, so if we can get Marty back on the webinar, could you please talk about examples on how you're coding the ICD-10 in your next-gen system related to PRAPARE, and how many you're using?
Yeah, the PRAPARE tool is great at prompting providers to use appropriate ICD-10 codes. They're in the Z59 series. Z59.0 is homelessness, 59.1 is inadequate housing, 59.4 is lack of adequate food and safe drinking water, and so on. We've adapted one for transportation barriers that's sort of general. Which one was that? 59.8, other problems related to economic circumstances. So yeah, they're all there, and you can. As I understand it, there's work right now happening in San Francisco with the Sirens Project, where they're actually exploring more specific ICD-10 codes for social risk factors. One of my colleagues here is working with that, is on that work group.
Yeah, I'm going to pitch it to Rosie, or also if Michelle's on. Any updates on the Siren work happening? And Rosie, I'm not sure.
Sorry, Albert. Could you repeat the question?
Oh yeah,
I was reading
no worries. Yeah, Marty mentioned some of the national work happening with the UCSF Siren Group. Any updates on what's happening with the ICD-10 coding?
I know. You mean I just want to clarify. Do you mean the with respect to kind of their work in gravity? I'm assuming that's what is meant. I know that we work closely with Siren and Gravity as well, and they had developed a crosswalk. Siren had developed a crosswalk, and then Gravity is, doing a lot of the work around interoperability and more specificity for the the food, housing, and transportation codes. So we're actually working in alignment. We just had a call today with Gravity, and we have monthly meetings with them to better align our our work, the social interventions, coding and mapping as well. So we are making sure that that we're aligning with a lot of the work and leveraging a lot of the national work out there as well. So if you have any particular organizations that that we should make sure to connect with, please let us know. So.
Great, and I'm seeing some chat box, so we actually have Laura.
Oh, Laura's on.
Yeah.
You could provide more updates.
Laura says in the chat box that Gravity recently submitted proposals to the American Medical Association and other groups to strengthen relevant SDH codes related to food, housing, and transportation. So great. And Lydia says, cool.
Yeah.
And thank you.
And link codes too.
Yeah. All right. So I have some direct questions for Corinne here. So someone is asking, how are you using Prepare telephonically or through your smartphones? And do you need to have patients download an app, or is there a web link, or is it also secure through HIPAA? So any background on how you're doing that telephonically would be great.
Yeah, I can definitely tell you how we've done that. We use QuickBase. It's a low code platform. It is HIPAA compliant. I really highly recommend QuickBase. It's very cost efficient, and you can really customize it. We did the same thing for our COVID-19 testing for our employees, our COVID screening tool for our employees. We developed an app in QuickBase. You can link this to your smartphone to an application that you've created for your health center, or to even to QuickBase as an app that's downloaded on your phone, and then you can have all your health center branding on there. It's an upgrade to have the QuickBase that is HIPAA compliant, but we do have that system in place, and it is a very seamless system for anyone that has a smartphone. I highly recommend it.
That's great to hear. Yeah. And the next question for you, Corinne, is someone would love to hear how you began your food pantry on site.
Yeah, well, that's a great question. We actually have great partnerships with San Diego Food Bank and Feeding San Diego Feeding America. And we have been getting food at a very discounted rate from the San Diego Food Bank for many years. Due to COVID-19, we actually applied for a grant and were awarded a grant from San Diego Food Bank to be a super pantry. And so we have been working with them for our diaper bank. We also worked with San Diego Food Bank. They're an excellent organization. Don't want to duplicate any work, but we've been a partner of the San Diego Food Bank for many, many years. I would really recommend reaching out to your regional food banks and setting up a relationship, MOUs, asking for grant funding, and really working on getting a discount on your food. We get food right now for 10 cents a pound from them. And we've been able to, it used to be about $1.66, I believe. We've just really been able to increase and ramp up efforts. And then in response to COVID-19, we're also doing a hot meal distribution for clients. It's Monday through Friday from 11 to 1. We run out of food at about 11:30, but it's a meal distribution with Feeding America, San Diego Feeding America. And they help us and they provide the meals and then we distribute them. We've had a great relationship with them as well.
That's amazing. And it definitely helps to leverage your local resources and foundations. And wanted to ask you a second follow-up question, Corinne, related to food pantry. So in terms of your data collection process, if a patient screens positive for food insecurity and then gains access to your on-site food pantry, would you expect them to have a subsequent negative response for the food insecurity the next time they screen?
We would expect that. Our case managers would so they do initial prepare as our patient intake. And then right now, we're not doing it very subsequently, even though this is such a short questionnaire. We're basically doing it once annually. And for the study, we did it more often. We did it about every month, but we would expect them to screen positive. And how we're tracking that right now is in a database that was created by the San Diego Food Bank. It's called Oasis Insights. And so our case managers have to do some work in seeing that the patient was connected and basically closing the loop, seeing that that same patient that was referred in received a food bag, and then they closed the loop in NextGen, showing that that patient received food and hopefully is food secure. So they can do notes and comments for the provider on that.
That's great, which is, again, also a nice segue. I think this could be applied to both you, Corinne, and Marty. When it comes to working with community organizations outside of the health center and enabling communication with them, what's some of the legal agreements or contracts you have in place? So for Corinne first, and then we'll go to Marty.
Sure. We do have memorandums of agreement and memorandums of understanding with all of our organizations that we work with. We do have signed contracts, and we have a contracts team. They also use QuickBase to manage all of our contracts. So we have a pretty, it's not seamless, nothing is seamless, but it is, it is come a long way in the 7 years that I've been at La Maestra.
Thanks, Corinne. Marty, anything to add?
Well, we are the same agency. So our community health center and our social services programs are all under the same roof. So we don't, we certainly have internal workflows and agreements, but they're not legal contracts. For external providers, though, we do similar things, memoranda of agreement. HRSA has the expectation that we have these updated on a regular basis, makes a lot of sense. And we do this typically with our, intimate partner violence program here in York County, with our shelter programs and so on.
Thanks, Marty. And yeah, we have a good juxtaposition here about, York County being, again, a social services and FQHC, and then we have La Maestra, who has strong relationships in San Diego. So thanks for sharing your perspectives on that. To go back to Corinne. Oh, go ahead, Marty. We're
ubiquitous. There are community action agencies throughout the United States. There are almost as many community action programs as there are federally qualified health centers, and I don't know that we all know each other very well. So I'd encourage health center partners to look us up, and community action programs to find your local health center and see about the partnerships that Corinne was just describing.
Perfect. And I wanted to reinforce your point, Marty, that HRSA does encourage all the health centers to, again, look at your MOUs or memorandums of understanding. And there's lots of upcoming TA that I can share with you all that will talk about partnership building and really building those agreements across the partners, whether that's community-based organizations or social services. So be on the lookout through the PHC Digest that happens or is shared every Tuesday. In terms of streamlining and interoperability, we have some questions related to kind of how you all are sharing data. So for either Corinne or Marty, could you talk about how your, again, EMRs are helping close the loop with the referrals and some experiences with interoperability, if there are any issues or challenges?
Corinne, do you want to go first?
You can. I was just going to say really quick, well, actually, I'll just do mine really quick. So just in that slide that I had, most of our services are on site. So we are closing that loop, that referral, when we're referring on that dropout that we had to our on-site legal advocacy, our on-site food pantry. That's a checkbox. And so that is very convenient for us. When we refer outside of the agency, it takes a lot of our case managers calling, following up, and doing a lot of legwork. We're very hopeful that I saw a question on here about Aunt Bertha. Here in San Diego, Aunt Bertha is not super prominent, but 211 is, as our community information exchange. And so that has a bi-directional referral system. So you can actually show that the referral was sent to Episcopal Community Services or Catholic Charities or whoever has housing available, and that housing what is able to be followed up and that loop's able to close. So I will just say that's how we've been doing it so far.
Thanks, Corinne and Marty.
And yeah, we try hard to use our system to the greatest extent to use, we can. It's fairly sophisticated in terms of providers without a whole lot of clicks being able to generate referrals to specialists, to medical specialists, to external agencies, as well as to generate internal referrals between disciplines, between medical and behavioral health, for example, and also within our agency between the health center and the social services side of our agency. So NextGen allows us to generate the referrals, and then when we receive, it's not actually a CDCA, it's not a data appropriate consult note that comes back from economic opportunity from our social services, but we do get a document that we can scan back, or essentially scan back into the patient's record. We are part of the state health information exchange, to which we upload medical information as our patients get services, and from which we download similar information. That's not data, that's just scanned images. And then we're working with our local hospital to have a CDCA exchange so that it is real data that's moving between entities. Not a lot of social work information there, it's mainly medical.
Great, thank you, Marty. And I'm gonna tackle this next question. So really thinking more upstream and how some of the SDOH data can be used for policy and legislation. Could either of you, Marty or Corinne, talk about how that data is being used above kind of the community or health center setting?
I think there's more potential than actual real use of the data right now. We are building the capacity. We at Nasson, York County, as well as other health centers around the state, are making the case for the fact that a whole lot of our patients are living without appropriate food, housing, or transportation resources. Our state does not fund these services nearly as well as it could, and to the extent that we're able to generate this data through ICD-10 diagnoses, as well as what we're able to do in terms of social services intervention, that can certainly be used for advocacy purposes. We do upload, again, to our health information exchange, the actual diagnostic codes. So we will soon, I hope, have the ability, the opportunity to make a case to payers that, our patients who have diabetes and very low incomes and food insecurity are really in need of more resources from you, please, in order to have better health outcomes. So I think there's a lot of potential here, but we haven't really realized it just yet.
Thanks, Marty. And Corinne, anything to add in terms of foresight or upstream kind of policymaking with SDOH?
Yeah, so the one thing that comes to mind is that our CEO, Zara Marcellian, does do a lot of national speaking engagements on our circle of care. And she actually spends some time in DC and just really works hard to make sure that at HRSA and at NAC, at other agencies throughout the country, that they kind of understand how amazing it is to, it's not maybe the most cost efficient model, but it is really value-based when you see the health outcomes for your patients, and providing these services on site has really, really helped us just to really have a great sense of community, and to have patients that are pretty much lifelong, and we can see their health outcomes over the years. And that is very, very rewarding. So I would say that we do a lot of advocacy, just kind of myself, our CEO, and then working with partner agencies and doing speaking engagements like this. And our CEO is very, very always speaking at national events. Yeah.
Thanks, Corinne. And I just want to congratulate again Maestra for again celebrating 30 years, and also for Marty at Nasson 50 years and over. So it's a long stretch, it's a long haul, so the work doesn't stop, you all. And I want to acknowledge that we have 1 minute left, so I am going to ask Eureka to just close out the session, and we'll be monitoring the questions and saving them for our next session next week. Thank you.
Thank you so much, everyone, for being with us today. I have launched the evaluation poll, so please take a moment to provide us your feedback. We do use this feedback for improvement purposes. We want to make sure that we're being responsive to all of you and your learning needs. Obviously, we can't answer every question, but we had such a robust conversation, and we really just want to thank you all for being with us today. So just some closing remarks. We already did the Q&A. Again, the webinar recording and the slides will be posted to the website as well as emailed. So we'll be sure to share those once they're ready. That takes typically about 24 hours. Again, please complete the evaluation, and please be sure to share any topics that you like from the PRAPARE team, or from our project team at NAC and AppShow. Obviously, with our support from Robert Wood Johnson Foundation, we're not limited to just PRAPARE. We really want to advance the field of SEOH data collection and really addressing those needs. So I'll keep the poll going. Let's see if I have other slides. Oh, and so we do have a wonderful announcement for next week. Part of our program with Robert Wood Johnson Foundation, we'll be launching a design sprint. You'll hear more about it next week, but the purpose and the goal of the design sprint, and we'll go into more detail about it next week, is really how do we use a different framework for doing something different, right? We've all been using maybe different strategies before, but this is a new framework that will allow health centers and their cross-sector partners to collaborate and to think about the issues and the needs of their community in a different way. So we invite you to join us next week. Again, it's a design. We're going to go over the design sprint. It's not the actual design sprint itself. That will be starting in February of 2021. But we want to go over what is the purpose of the design sprint, what we hope to accomplish from that, and just to give you guys an opportunity to ask us any questions as well. So please be sure to register for that. Even if you're interested, you want to get more information, please register. And we encourage you to also invite your community sector, your cross-sector partners. So any community-based organizations, any health departments, anybody that you collaborate with, please ask them to join us. We'd love to hear from them as well. Of course, my computer's acting slow, and that's it. So thank you again for joining us today. If you have any other questions, please be sure to email us. We love hearing from you. So thank you again for joining us today. And we want a sincere thank you to Corinne, to Marty, to Rosie, to Vivian, and Albert for getting us together today and getting us this very important information to understand that it's not just important to collect information on social needs, but what are the interventions that are being used to address these needs? That's really important information that we need to have. So thank you, everyone. Have a wonderful day. Be safe, and we hope to see you next week. Bye.
Thank you so much.